All right, we are going to get started. Good morning, everybody. I know we have over 250 people joining us via a conferencing system, so we will be working with them to ensure that they can hear accordingly as well. But I am Kenneth Grunke, Executive Director for PLOWS Council on Aging. And I do appreciate you taking time to be here, hopefully to hear some very helpful and informative information regarding what has been the biggest topic lately on all of our minds, and that's the coronavirus. This opportunity would not be possible, though, without the support and partnership of Moraine Valley Community College, the Illinois Health and Hospital Association, Coordinated Care Alliance, and of course, Northwestern University, who I will be introducing in a brief moment. For those of you who are tuning in via conferencing system, please mute your lines. This will prevent disruption for the presentation. We will be offering a Q&A session at the conclusion of the presentation. And we ask that you please submit your questions via the chat option that should appear on the conferencing system as well. We will, of course, also be taking calls live for those that are attending in the room here this morning. On that note, we're going to move right into the presentation. Dr. Ison is Professor of Infectious Disease and Organ Transplantation at Northwestern University, Feinberg School of Medicine, and the Director of the Transplant and Immunocompromised Host Infectious Disease Service at Northwestern Memorial Hospital. Dr. Ison is an expert of respiratory viral infections and has recently participated on the President's H1N1 Subcommittee, NIH, and BARDA on issues related to influenza in hospitalized and immunocompromised patients. He has led research programs leading to the approval of the only available IV medication, Permavir, and single-dose baloxavir treatment for influenza. He was involved in the NIAID Influenza Research Collaboration, which focuses on research priorities for the NIH, and is a member of the IDSA, CDC, and World Health Organization Influenza Treatment Guidelines Committees. He is also at the forefront of the NIH's response to coronavirus as the chair of the Safety Oversight Committee for all research on treatment of coronavirus. And so, Dr. Ison, thank you so much for being here today, and the floor is yours.
Thank you, and it's a great honor to be here today. If there's any problems hearing this, please just put a text in and we'll try to troubleshoot that. So I always start with disclosures. I'm not doing anything with companies related to treatments or vaccines for this, although as Ken pointed out, I am involved in the NIAID, the NIH's branch on infections, program on research. So in the next half hour or so, what I thought I would do is talk about a couple of issues. The first few minutes will be boring and a little bit scientific, but I think this is to give you some background that will be very helpful in debunking perhaps some rumors that may or may not be true out there. We'll then talk a little bit about epidemiology, and this is where I'm going to be focusing on its impact on the older adult. And again, as I will highlight in a few minutes, and I think as we've seen in places like Washington, the older adult is going to be the one that's going to bear the brunt of this infection. I'll talk briefly about some of the efforts to prevent and manage this infection, unfortunately all of which is mostly experimental or social distancing type activities. Lastly, I'll spend a few minutes talking about organizational preparedness. I'm not going to be telling each of you what you need to do with your particular organization, but giving you a framework that may be helpful in developing a plan that's relevant for your group. So let's start by talking about what coronaviruses are. These are something that every single one of us gets once every couple of years. Our children get 2 to 3 coronavirus infections every single year. It's an envelope virus. The reason why this is important is detergents, soap, and alcohol will disrupt the outer membrane, and that's the best way to prevent from transmitting this virus. It's a single-stranded RNA virus, which means that You would expect it to mutate very quickly, but it has a proofreading gene that prevents a lot of mutations occurring. And that's why the virus that we've seen, although it's changed slightly since the first case in Wuhan, will stay relatively stable, which is good from a vaccine and therapeutic approach. There are two types of coronaviruses that we think about. There are the human coronaviruses that cause disease in humans. These are either the alpha coronaviruses or the beta coronaviruses. And again, these have fancy names, but I call them cold viruses. This is the cause of about half of colds in humans around the world. So we've all been exposed to these types of viruses. The second type of coronaviruses are animal coronaviruses, and the ones that we've been most focused on are bat coronaviruses, because the three viruses that have affected the human population in a severe form, SARS in 2002, 2004, MERS coronavirus, which came up about 10 years ago and is still a global problem, and this most recent SARS-CoV-2 that's associated with COVID-19 starting in 2019. These transition from animals, either directly from bats or from bats to animals and then to humans. They can replicate in the human airway and be transmitted from person to person. This is a phylogenetic tree of the coronaviruses, and as you can see on the bottom of the group are the human viruses that are distantly related to the animal viruses. You can see that the MERS virus is very different from the SARS coronavirus and the SARS coronavirus 2, again just suggesting that from a virus type, this is far more related to the SARS that caused outbreaks throughout Asia and Toronto in 2002. Where does this virus replicate? Well, we're starting to get a better sense of this from sampling. We do know that the receptor for this is a protein called ACE2, which is on the respiratory epithelium throughout the upper and lower respiratory tract. The virus replicates both in the upper airway, the nose, and in the lower airway in the lungs, and appears to replicate more efficiently in the lower airway. And this is why sometimes we've heard stories where patients had a positive swab, they were negative, and they had a later positive. It doesn't replicate as well in the upper airway, and that doesn't necessarily represent a new infection. It just reflects the challenges with detection in the upper airway. In terms of immune responses, our cells in our blood are what are primarily responsible for the clearance of the virus. They also produce antibodies, and what we've learned from patients in China is that the antibody response comes up very quickly after infection. By 7 days, all patients have an IgM, the early protective antibody, which means that they won't be reinfected by new infections if they come again in contact with someone with coronavirus. A few days after that, there's an uptick in the IgG response. This is something that stays with us for 2 to 3 years in general, so is something that will again come up and protect us over a longer period of time. This is important because it also shows that we can develop vaccines that if you're exposed to the proteins of the coronavirus, you'll develop antibodies and they'll persist with you for a period of time, helping to control spread of this virus. So some of the next couple of slides we all know, but again, just to remind ourselves about the timeline of the development of this disease. While there was ongoing infections, as I'll show you, as early as about December 1 in China, the first severe cases were recognized at the end of the month, just before Christmas time. And on December 31st, the World Health Organization received a report from Chinese authorities of a cluster of abnormal pneumonia cases in Wuhan, China. These patients were tested using molecular testing to look for all of the known viruses, including SARS and MERS, and all of those tests were negative, suggesting that this was a novel virus. Just about 10 days later, on the 9th of January, the WHO announced the Chinese had identified this novel virus. It was initially called the 2019 novel coronavirus and has been renamed SARS coronavirus 2 at the most recent WHO consultation. The disease caused by this virus is called COVID-19, and that's the term that most people are comfortable with and that I'll use for the remainder of the talk. January 20th, there was confirmed transmission from humans to humans, documented well in Vietnam and China. A few days later, the International Health Regulation Emergency Committee of the WHO declared this a public health emergency of international concern. And the following day, the Secretary of Health and Human Services, Dr. Ison, declared this a public health emergency. The reason why that's important is that allowed more resources to be made available to things like CDC and local health departments. It also put into place some rules that hamstrung the development of diagnostic testing initially. Where are we as of last night? And again, I think the critical thing is this is a very rapidly moving event. Just from putting the slide together on Friday to updating it last night, there's been a lot of changes, and this is something that changes from day. Clearly, this is now something where we have sustained human-to-human transmission on most continents in the world, definitely North America, Asia, and Europe. And so the numbers, while increasing in some countries, are expected to go up further in other countries, as we've seen here in the United States. In terms of locations that are currently a priority for the United States, the CDC categorizes a country in terms of risk to travel into 4 different levels. 4 is an area that no country is listed in which no one is allowed to travel from the United States. Level 3, which is where we recommend all non-essential travel be avoided, is currently in place for China, Iran, Italy, and South Korea. Level 2, which is enhanced precautions, where it's recommended that individuals that are elderly or those with underlying medical conditions avoid travel, which currently includes Japan. And then routine precautions, meaning it's okay to travel, you just should be very cautious while you're there, is currently Hong Kong. The other issue that was updated over the weekend by CDC is a recommendation for all patients at risk for serious illness from COVID-19 to restrict their activities moving forward. This means that they should begin thinking about stocking up on supplies, trying to keep a distance between themselves and others, especially if the others are sick, and to avoid crowds as much as possible. And the media has reported this as a advisory to adults 60 or older to stay at home as much as possible. And again, I think reading what the CDC specifically says, I think will help you think through, because I know May is a month where we typically celebrate the older adult, where we may have to rethink how safe it is to do all of those activities. So this is a timeline of what happened in China. The grayish green bars are the onset of illness, and you can see there's about a week difference between where that peaked and where the yellow bars, which are hospitalizations due to coronavirus, develop. And again, this is very typical, as I'll talk about later. People typically are sick from somewhere between 3 and 7 days before those that are going to be sick enough will be sick enough to require hospital admission. We've gotten a lot of data from China. They have over 80,000 patients that have become sick. And what we've learned from this is it takes from initial infection somewhere between 3 and 7 days before the majority of individuals begin showing signs of symptoms, although it takes up to 14 days for some patients to start becoming ill. The interval between when they first become sick to hospitalization is about 10 days in China. So again, this is helpful for us to think about when you're observing a patient that may be sick, when to expect them to get the sickest. And those patients that are hospitalized, there's usually about a 1 or 2 day time frame from when they're just admitted to the floor to requiring ICU level care. In terms of what we've learned about the makeup of the patients that have gotten sick in China, and one of the things that we have to take with all of the data that we have is that for the most part, only patients that are sick enough to come to the attention of healthcare professionals, which in China has typically been in the hospitalized adult, those are the patients that are tested. There's probably a large number of individuals particularly younger adults that are getting sick, but not getting sick enough to require hospitalizations and may not be captured well from the data that we have. But from those patients that are sick enough to seek care, which is generalized hospital care, the highest proportion of patients are those that are over 50 years of age. 50 to 65 accounts for about 29% of patients, and greater than 65 years of age are being admitted to the hospital. What's concerning, though, is if you look at those patients that get severely ill, meaning that they require ICU level care, mechanical ventilation, or die, half of those patients are those individuals that are over 60. So clearly that's a population that is more likely to get severely ill. The other factor that we know is underlying medical conditions. And while I think a lot of people think of themselves as being very healthy, if you look at the conditions that were most common in the patients that got more severely ill, it's diabetes and hypertension. So again, relatively common comorbidities that many people may have. So just because you're 65 and think of yourself as healthy, if you have some of these relatively common infections, they're added risk factors for your patients. In terms of presenting signs and symptoms, the real challenge with this is this looks exactly like a regular cold, flu, or other respiratory viruses when people initially get sick. Common symptoms for patients, though, when they initially get sick and present for care: cough, sputum production, fatigue. Fever is present in about half of patients when they initially present with illness. In terms of outcomes, about 1.4% of patients from the data that's been collected from China have died. About 5% of patients were sick enough to require ICU level care, and about 2.5% of patients were a breathing tube. And so I think this is going to be helpful in thinking about how this will affect patients in the United States. So again, to summarize, what are the common presenting signs? The most common are fever, dry cough, and fatigue. The cough may eventually become productive. Patients that have more severe infections typically have very high fevers, above 39 degrees Celsius. The cough oftentimes has blood mixed in with the sputum that they're producing, and blood tests show that their kidneys begin not functioning very well, and their total white blood cell count is relatively low. The other thing that I wanted to draw your attention to, since many of us are providing care to these patients, is healthcare workers are not immune. In China, they account for about 4% of patients that have gotten sick, and that 15% of those healthcare workers that did get sick required ICU level care or a ventilator, and 5 of the 1,700 patients ended up dying. Thankfully, it's a small percentage, probably because they're relatively young and healthy, but again, a sign that healthcare workers aren't immune to severe infections. So again, really highlighting the focus on age. If you look, adults, so 30 to 79 years of age, account for about 90% of the cases. Patients 60 to 69 account for about 26%, 70 to 79, 12%, and then 80 and above is about 5% of the patient population. So the majority of individuals that are getting sick with this infection in China are patients that are older. The important lesson that we learned with the Diamond Princess, which received a lot of press, is that, again, the virus can spread, particularly in contained quarters. 706 of the 3,711 patients eventually got infected. Of these, 132 crew members. So again, even people that are taking care of the sick can get sick. Thankfully, mortality from this is relatively low, 6 deaths so far. In terms of what we've learned from other countries, I think from my perspective, currently the best data that we can get is data from Korea. And this is in part due to information presented in this table here. Testing in Korea has been incredibly widespread. They literally have drive-through testing where you can go, order a coffee, get your nose swabbed, and by the time the coffee is ready, you have your result. That's what we need here in the United States. We just don't have that testing so far. And as of a week ago, they had tested over 100,000 individuals. And because of that, they've captured a much better spectrum of disease. People that are well enough to go get a coffee are clearly not severely ill. And so they're capturing that the under part of the iceberg that is the more milder cases. But with that, they've also described using this broad testing, what are the patient populations that are getting sick, and what is the relative mortality to date of those patients. So you can see probably the highest percentage of people that are getting sick are the young, 20 to 29 years of age. But as you can see, there's no patients that have died from that infection. Those in a parenthesis is the mortality among that patient population. As you start going up in age, the number of patients that are getting sick is increasing, but the proportion of mortality is relatively low. So about 0.2% in adults 30 to 49 years of age, 0.7% in patients 50 to 59 years of age. And then once we start going above that, that's where the mortality starts going up. 60 to 69-year-olds is about 1.3%, 70 to 79-year-olds gets up to 1.9%, and 80 and above 3.2%. So again, these numbers will lag a little bit behind and likely will go up in the near future, but again, showing a stepwise risk of infection and death in the older adults. Where are we in the United States? Thankfully, the circle around Chicago is relatively small, but growing. You can see very large numbers in Washington, New York State, the Bay Area in California, and then smaller areas throughout the country. The graph here, though, on the bottom really shows the uptick in cases over the last couple of weeks, where we really have seen significant rises in the number of identified cases. Part of this is because we now have better access to testing, still not optimal, but much better than they were even a week ago. And so we're able to identify more and more patients. What I think, though, is important, and I'm going to spend some time on this, is what are the source of these infections? And if you look at the third most common source of these infections, it was that nursing facility in Kirkland, Washington. And I'm going to spend a few minutes on this because, again, I think it's relevant to people that are focused on the older adult. What ended up happening in this setting is that a sick worker came in, infected other patients within the facility, and has then sickened other healthcare workers and other patients as minutes. What was concerning is that the sequencing data for the virus in the first patient that was identified to be sick from this nursing home was related to the first patient that was identified in the state of Washington 6 weeks before, that suggesting that there was some ongoing community transmission that wasn't recognized. Thankfully, this happened in an area of the country where the best people working on sequencing and genetic information on viruses is located, and they were able to get this information out relatively quickly. And then I'm going to move back in a second. This is a press release that came out over the weekend from the nursing home. So when the first case occurred, they had 120 residents in the facility, and currently 50% of those patients are currently symptomatic with influenza. 22% of those patients have already died. So this really shows how dangerous this virus can be in closed settings, particularly those that have debilitated. The real challenge, though, is here on the other side, where we can see that almost 40% of the staff became sick with symptomatic illness, and that's a real problem because those patients, those staff, can transmit on to the few uninfected patients. So this is why, as we'll talk about in a second, our focus needs to be both preventing our sick employees from getting our patients and customers sick, and then likewise, once we have individuals sick, figuring out how to make sure that the illness doesn't sicken our staff and that they go on to sicken others. So in terms of modeling, it's very helpful to understand how we would expect this to play out over the next couple weeks. We know that the R naught, the number of patients that are infected from one individual patient, is about 2.5. That's in comparison about the same as the rate of transmission for Ebola, but markedly less than things like measles, which can infect 11 to 18 patients for every index patient. We expect a case attack rate of about 30 to 40% in the community, with a doubling time around 10 days. We expect of those that get sick, about 10% will require hospitalization, 1 to 2% will require ICU level care, 1% ventilation, and about a 0.5% mortality. So what would this look like? In the United States, in the first major wave, we expect 96 million adults to get sick, 4.8 million to get admitted to the hospital, somewhere around 1.9 million requiring ICU admission, and 480,000 deaths. How does this compare to standard seasonal flu, just to kind of calibrate our thinking? So that measures about 17 times what we would expect for a average flu season, and about 6 to 10 times what we'd expect the mortality to be for seasonal flu. So while we've seen bad flu seasons, we have not seen one quite this severe. And then again, just to reiterate the importance of the elderly population, and again, it depends on which country you're looking at. China, where they're only really seeing the severe infections, those older adults have a fatality rate up to 15% of those 80 and older, compared to about 3.2% in Korea. Again, that's because we're capturing more of that denominator. Nonetheless, in all cases, the mortality rate goes up with age. And so we can expect our older adults, those 60 and older, to really bear the brunt of mortality. Now, a couple things to keep in mind. We have some significant knowledge gaps, and these will calibrate some of our thought process as we move forward. We know that there's likely a significant number of patients, particularly the very young, that have asymptomatic or mildly symptomatic disease, and currently most testing programs don't capture those patients. So the real total number of patients, which is what we would use to identify the true mortality rate of this disease, isn't well known. Testing currently has been limited to known contacts and hospitalized patients. And again, there may be patients on the outpatient that aren't getting as sick that we need to understand as well. And there, to date, haven't been seroepidemiology studies to understand what total population became ill. Everyone's fixated on knowing how do we prevent transmissions, and yet we have some sense that droplets are critically important for transmission, but there's a very little data that's available on the true rate of transmissibility of this infection. We'll understand that better in the very near future. Thankfully, there's been fewer healthcare transmissions than some other infections. I personally think we've been lucky because we've, in general, known when someone's sick is coming to the hospital. And this is why it's really important that if you have someone that's sick, you don't just show up at the emergency room or at the doctor's office. You call ahead so that they can put the protection in place to keep the healthcare workers safe. If they get sick and die, they won't be able to take care of the patients. And then, although we recognize that there are some things, older age and comorbidities, that are risk factors for fatal disease, we don't yet really know which patients are going to progress to a fatal disease, to pneumonia requiring ICU level care, and which patients are going to recover. Again, we'll get some better sense of this in the near future. Lastly, what are we doing to get prepared about prevention and treatment? There are no vaccines for any coronaviruses to date. There are 2 lead vaccine candidates that are starting clinical trials soon. What we do know is social distancing works. Closing China gave us 2 months. If that hadn't happened, we would have had where we are today 2 months ago. Travel restrictions can help. School closures definitely have been proven to be very effective, and restrictions on large meetings are something to be expected, to be recommended, and are helpful. The most important things are hand hygiene, and this is ideally with soap and water. Sometimes you don't have a sink present. Really, the most important thing is something. Alcohol hand gels should work nearly as well as soap, and so if you don't have a pump of hand gel on your desk, you should get one. Not only for your use, but everyone who's coming in your office. You should have it in your car, carry it with you if you're doing services in the community. The more you wash your hands, that's going to be the best likelihood to protect yourself. There was a lot of enthusiasm for masks initially. What has become quite clear is you don't need those masks for otherwise healthy patients out in the community. They're really helpful if someone is sick to prevent transmission to other individuals. They don't work very well in protecting you from infection. So if you're not a healthcare worker, you don't need the masks. In terms of management, there are a number of different things that have been utilized to date that have unclear benefit. Steroids likely are very harmful and shouldn't be used in most cases. IVIG or convalescent plasma may be something to consider. We don't have that yet here in the United States. High-dose oseltamivir, a flu drug, doesn't seem to work very well. And there's a lot of enthusiasm for an HIV medication, which is a combination called lopinavir-ritonavir. The challenge is this has a lot of drug interactions and may cause problems downstream. And there isn't a lot of data to support its efficacy in this infection. Because of its mechanism of action directly inhibiting the replication of coronaviruses, a drug called remdesivir, which is made by Gilead, is undergoing clinical trials throughout the United States and globally. As a disclosure, I am the chair of the DSMB for this trial. It's a nucleic acid, so it basically blocks the virus from replicating. It's been shown to be effective in test tubes against all circulating coronaviruses and has been tested in animals for preventing severe illness and death with MERS coronavirus. And so that's why there's a lot of enthusiasm for this drug. Now, a couple of things about timeline. Vaccines will not be available in a month. It just won't happen that quickly. We'll be lucky if we have a vaccine in a year. The two lead candidates are using technologies that haven't been used for commercially available vaccines before. They have the advantage of being produced very quickly and very efficiently, but they require a series of tests, phase 1, phase 2, phase 3. Even if moved very quickly, I suspect it'll take somewhere in the neighborhood of a year before we even have them available. The last thing I wanted to highlight is we're mighty lucky, in part because of communication, in part because of cooperation, and because of technological advances. And this slide was in a recent article in JAMA where they compared SARS from 2002 to this coronavirus, COVID-19. We first recognized the virus in November for SARS. We didn't identify the virus that caused it until April, so 4 or 5 months later, but we were able to close the window and stop this outbreak. We identified the first case in early December, had a virus identified within the first week of January, but it spread much further than the other SARS coronavirus, and so will be with us for a longer period. So changing to the last couple of minutes about operational preparedness, and again, these are from some guidelines that are available for businesses from CDC that are available from their website. The primary objectives in developing an operational preparedness plan and being prepared for COVID-19 is to reduce transmission among your staff, to protect people who are at the highest risk of health complications, that's the older adult and patients with underlying medical conditions, maintain your business operations through the peak of this infection, and minimize the adverse effect on other entities in your supply chain. And again, a lot of times you're helping get the services at home so an older adult can leave the hospital. That's going to be very important because if there's a logjam of patients in the hospital, those beds aren't available for the sick people that need to be admitted. To do this, you need to do a couple of things. And I'm not going to tell you how to solve problems for your individual organization, but give you a framework. You need to assess your essential functions and the reliance that others in the community have on your products or services, and figure out how to mitigate impacting those essential services. And be prepared to change your business practice. Just because you've done something the same way in the past, you may have to think about alternative ways to accomplish that goal with using different technology or different approaches. So first and foremost, you're more likely today still to get influenza than coronavirus 19. So it's still recommended that individuals get their flu shots. This will help protect you against flu and will protect you from getting sick even if you get the flu. The reason why that's important, that helps the hospital. If you don't get sick enough to go to the hospital with the flu, you save a bed for someone who's dying for coronavirus. So really this is critical. The CDC recommends the flu shot for caregivers of adults over 50 years of age and caregivers of people with medical conditions that put them at increased risk. So again, older adults and those with comorbidity. And so again, patient-facing individuals that are seeing older adults really should be getting their vaccine every day. Then, specific to the coronavirus, really think about ways to prevent getting any infection, not just this virus. Avoid close contact with people that are sick. Avoid touching your eyes, nose, and mouth. This sounds easy. We involuntarily do this about 100 times a day, but thinking about it may help you prevent yourself. Stay home when you're sick. Seems easy to say. How many of you have gone to work when you've had a cold? You can't do it. You got to stay home. You don't know whether that cold is coronavirus or seasonal coronavirus. We need to be thoughtful about making sure others aren't made sick by your illness. Cover your cough or sneeze with a tissue, throw that out immediately in the trash, and then disinfect things, your hands, make sure you have wipes to clean surfaces. This is the way that we're going to protect ourselves and others. The other things, again, you've heard about the hand washing. I'm not going to spend a lot of time on that. You can also use hand gel. Face mask, we've talked a little bit about, really should be used for healthcare workers, not for the public at large. The other thing is you want to encourage your employees that are sick to stay home. This is particularly true if they have fever, if they have severe respiratory symptoms. They should notify their supervisors. And if they get sick and are diagnosed with coronavirus, it's important that they let their supervisors know so that they can do things to mitigate their contacts. If a patient comes, or if a staff member comes to work and is sick, you need to immediately isolate them from other patients, again, to minimize exposure to others in your facility. You should really focus on staying home while sick, respiratory etiquette, and hand hygiene. There's other things you can do. You want to make sure that you have routine environmental cleaning. Something as simple as the buttons on your elevator. How often do those get cleaned in such a way that you're preventing someone who just has coughed or sneezed from touching the button and then another person pushing the same floor and getting sick themselves? There's a lot of common surfaces in conference rooms and whatnot. Those need to be wiped down after every use. Consider having a travel policy if this is relevant for your organization. Spring break is coming up. Is it okay for your employees to go to Europe? I don't know. I work for Northwestern. It's currently against policy for us to travel internationally. So again, you have to think about what's relevant and right for your employees. And keep in mind, spring break is coming up. So that's really important to think about. How to approach an employee with coronavirus confirmed disease or exposure to a known disease. If an employee is confirmed with coronavirus, employees should be informed that should inform fellow employees of their possible exposure. This is important so that they know if they get sick that they can seek care and give factual information to their provider. Again, you have to be consistent with the ADA and not bring shame to that individual. Employees exposed to coworkers should refer to CDC guidance for how to conduct their risk assessment about potential exposure. And the reason why they have to look there, this is changing quickly. So what I tell you today may be different a week from now. Employees who are well but who have a sick member at home to notify their supervisor and again refer to current CDC guidelines. In general, it's recommending these individuals. Things I think for you to think about as we start getting into the period where we're going to be peaking of this illness. Who in your organization can telecommute and what employees will need to telecommute to be safe? Do you have the infrastructures to be able to do that? Probably the most important question to ask yourself is which employees have children in daycare and schools, because those will close at some point for likely several weeks, and you need to be prepared with your employees that are not going to be able to come into work because their kids are home and need someone to keep an eye on them. Again, planning ahead and having a plan for this is a lot better than waiting until the day that you find out that 6 of your employees can't come in because their kids are at home because school was canceled. How do you handle patients who are sick? Currently, 14-day self-isolation is recommended for people who are concerned to possibly have coronavirus or confirmed with infection. The other question to ask yourself is who at your organization will determine when it's safe for that individual to return to work. Prepare for possible increased number of employee absences. At some point, there'll be a large number of your employees that may be getting sick from this infection, How do you maintain your core functions when 5, 10, or 15% of your staff may be absent because of school closures or personal illnesses? So you should have a plan in place to monitor for and respond to absenteeism, and develop and implement plans to continue your essential businesses in case you experience higher than usual absenteeisms. Lastly, and I'm not going to go through all the details, but you should all develop an infectious disease outbreak response plan. Hopefully you have a disaster preparedness plan, but one that's specific to infectious diseases would be helpful not only in this situation, but overall. The key tenets of these are that all employees that are sick should stay home and away from the workplace, to focus on respiratory hygiene and hand hygiene, and routine cleaning of commonly touched surfaces. And this will be available in the slides for everyone after the fact, but these have been outlined on this slide. I'm not going to bore you by reading something you can read yourself. So in conclusion, there's expanding incidence in the United States. As you saw from that graph, the red bars are going up exponentially. Thankfully, most cases are mild, and for most of us, it's going to be a bad cold that we're going to have to suffer through. But severe disease may occur with increased mortality in the elderly and those with underlying medical conditions. How to prepare yourself as an organization for COVID-19, prepare for absences, prepare for options for telecommuting, and develop your ID outbreak preparedness plan. And then most importantly, you've heard it 100 times probably since Friday, wash your hands, cover your cough, throw out any Kleenex that you've used, avoid touching your ears, nose, and mouth, and if someone's sick, stay away. It was a great honor to chat with you today. I'm happy to answer any questions that you may have. Thank you. So for those that are on the web, you can use the chat feature. There's a bar up at the right top that you can use. There's one that says chat. Go ahead and get in there, and we'll be able to answer any questions that you may have. Questions here in the room?
So I know one of the questions that came up is, given the vulnerable population, older adults that we are really focusing on, the same individual happens to be in a hospital system at the same time in a village or a community, a township, at the same time going to a social service, human service provider, at the same time a skilled nursing facility. So is there some sort of way that as providers we can come together and put together more a collaborative action plan? I know you spoke a lot about organizations being able to how to identify that, but how as collaborators can we kind of work better together more effectively, knowing a lot of times we see the same person, that same individual?
I think that the best thing is to utilize your channels of communication between organizations. I think that that's really important. For example, we have a meeting today where we're finalizing our approach at Northwestern for patients with COVID-19. We've been in close communication with other hospitals in the city, hospitals in, for example, Seattle, to see what they've done and what they've learned from taking care of the patients. There's work through the Illinois Hospital Association, through the IDPH to facilitate these communications. What I would say is leverage your communication and really think about, if those aren't present, to see how you can create those linkages now to understand how each group is preparing, because I agree, not only will you have some of the same challenges, someone may have thought about a solution you haven't thought of that might work very well for your organization.
We also have a question that came through here. What should we be advising our patients when they are wanting to travel to higher outbreak areas such as Seattle, Northern California?
Can you repeat that again, sorry?
What should we be advising our patients when they are wanting to travel to higher outbreak areas such as Seattle, Northern California, etc.?
Yeah. Well, I think that the CDC gave us very helpful advice over the weekend, where they basically said individuals that are 60 and older and those with risk for severe disease, so underlying medical conditions, should avoid exposing themselves to areas that have ongoing person-to-person transmission. That is going to change. So today it's Seattle, it's New York, it's California. A week from now, it may be the whole country. So this is something where I think you have to look at the maps. I personally find the map in the New York Times to be the most useful to seeing what the real-time data is. There's also a map that's a little harder to read, in my opinion, on the CDC website to understand where high rates are. I was supposed to go to Seattle for a meeting next week. I'm not going. So I think you just have to balance your risk assessment of risk of exposure. What would be the implications if you got sick and I take care of transplant patients, I can't get them sick.
Did you foresee at some point during?
Correct. So the exact duration hasn't been determined, but again, if you look at Japan closed their schools countrywide for a month. The schools are all closed in northern Italy, for example. This will all be calibrated to how much disease is present in the area. There's already one school that's in this area that's closed while they're doing cleaning and whatnot. And so it's going to happen. How long will depend on how much disease is going on within the community, but it will happen.
For population, which hospitals are?
Yeah. So probably any hospital in the area could take care of those patients. Definitely the larger hospitals, the academic hospitals, could do so. Currently, no hospital has their own in-house test for coronavirus. We're still relying on tests from the public health department. There will be soon more commercial tests that are available, and that may improve things. I think the challenge of the homeless population for isolation is one that a call to the IDPH or if you're in the city of Chicago, CDPH, to see what resources they may have for those individuals would be important as well.
So many municipalities host activities for seniors centers. What recommendations would you have? What level of those services should we?
Yeah. So I think again, I can't give you an answer for all organizations, but I think that you have to look at what services you provide, what alternatives for some of those services that you could still offer to patients maybe outside of a unified facility. Sometimes it's meals. That's essential for people to have. Again, if you have the capacity to have those meals delivered at home instead of at the communal center, when we get to a more severe case of local transmission, that may be more appropriate at that time. At this point, I think that the critical thing is that there needs to be some way of assessing people that are coming to the home or to the facility to see if they have any illness in any way. Those patients that are sick should not be brought into the facility. Again, I think that the case that we're seeing in Seattle shows that one sick person can have exceptionally dire consequences to the patient population. Again, you have to, I think through how to mitigate some of that. Things like making sure there's plenty of hand hygiene in the facility, screening for individuals that are sick on arrival, and having some way of getting information from people if they go home and get sick the next day, because if they don't come back, you won't know that they're sick and may have exposed others. Other questions? Ken's helping with the questions online. It's hard for me to do both.
There was a question about how long does the virus survive?
So there's not great details. It's an envelope virus, so it's not going to last forever. It depends on what type of surface it's on. Smooth surfaces like these, several hours to a day. On surfaces like cardboard and whatnot, they're going to live less because they'll dry out more readily. It'll also depend a little bit on the humidity. Drier spaces, it may lose its infectivity a little bit quicker, but in general about a day. But if you were to have a very humid location, maybe longer.
There's another question about, can you talk a little bit more about community spread, if we should cancel non-essential meetings?
Yeah. So there hasn't yet been a recommendation by the CDC or local public health services about canceling large meetings here in the United States. There have been groups that have preemptively canceled those meetings already. But if you look at areas where there has been more ongoing community spread, that has been done. France, for example, has limited all meetings of 5,000 or greater to not occur. Italy closed down all public gatherings for several weeks. They canceled Carnival, which is a huge moneymaker for the city of Venice. So once there is more confirmed transmission, we will see recommendations to avoid that. That's just not here yet. Some of it is maybe specific to organizations. We saw Amazon, for example, over the weekend encourage people to telecommute and not come in to work because there was a sick employee in one of their facilities. And so again, Seattle likely has more ongoing community transmission than we are in Illinois. That may change, and it's something where we have to keep abreast of the current guidelines.
And I think it's an interesting topic because this morning we've seen in Cranes that the cardiologists canceled their big conference at McCormick, but yet the American Society on Aging, which many of you folks I know will be attending in Atlanta, is still on.
Yeah, and there, in the medical side of things, there's been a huge number of medical meetings canceled. A large liver meeting was canceled. CROI, the largest global meeting of HIV providers, was canceled as a live meeting. Several of the meetings that I had planned to attend have been canceled. So I do think we're going to see that in the near future is happening more and more.
Will the heat in the summer kind of curtail the
So this virus has never affected humans, so we don't know what the seasonal variation for this is. If you look at seasonal coronaviruses, they typically are with us year-round with peaks in the spring and the fall. How well this virus acts like seasonal coronaviruses, we'll have to wait and see. Anyone who tells you it's going to go away at a certain time doesn't know what they're talking about because we haven't seen it through a full year to know what the seasonality will be.
Dr. Ison, there's a question that asks, where can patients get tested? Only at hospitals or also in doctors' offices, clinics?
Yeah, so this is something where you're going to have to watch as things change over the next week. Currently, in the state of Illinois, testing has to go through the Illinois Department of Public Health, or CDPH. There will be more tests coming online through things like Quest and LabCorp. There will be likely hospital systems that develop their own in-house tests that they have. I think the critical thing is that if you think you have coronavirus, don't just show up. That's going to cause a lot more problems. What's recommended is that you give a call if you are worried about having coronavirus. Call your doctor, call one of the hotlines. Many of the hospital systems have a specific page or email or phone number that you can dial. I know at Northwestern we've got a coronavirus hotline. I'm sure most of the larger hospital systems have this. If you are wanting an appointment with your doctor, again, don't just show up. Call them, tell them what symptoms you're having. tell them why you want to come in. They may advise you to stay home. Testing can only be done in selected patients. It doesn't, we don't have a real-time response. It's not something where you get tested and an hour later you have an answer. Hopefully, again, that will improve over time, but at this point, it does require some planning and approval to get that testing done.
Now we're at 10 o'clock here. One question coming in from the medical side. Since it is very difficult to differentiate between a common cold, influenza, and coronavirus in a dialysis setting, can we redirect presumptive patients to ER for further management? Are masks offered to suspected patients enough to protect the rest of the patients in the building?
So I think in that kind of setting, you would want to have the patient that was symptomatic evaluated. Again, I think I can't give guidance for all dialysis centers. There are some guidelines that are available from CDC. But in general, what's recommended is that at first they get screened for routine seasonal viruses, because if they come up positive with influenza, likely that's what they have and not coronavirus. That can be accomplished. If that can be accomplished in a space that keeps the patients separated from other patients in the dialysis unit, it can be done there. Otherwise, they can be sent for evaluation to the emergency room. Again, they shouldn't just send the patient. They should call ahead so that the facility knows that to expect the patient and to isolate them as soon as they can.
We are at a little over 10 o'clock. I know we wanted to end on time. Obviously, if there's additional questions, please continue to filter those to either ourselves. Dr. Ison's contact information will be shared. This session will also, or is also recorded, and we will also send the slides out to folks as well. Dr. Ison, thank you so much for joining us. We really appreciate this.
Thank you.
We give him a round of applause, please.
Thank you. Again, I think just to conclude, this isn't going to be the end of humanity. We're mostly going to do fine, but we need to be thoughtful about ourselves and our colleagues and our friends and family. Wash your hands. Don't go to work sick. Don't be a hero, because being so could really affect other individuals. For the businesses, I think it's time to really think about some of the questions that you have, work as teams of experts, and really think through some of these key questions that I raised to help you prepare for when there's more disease in the community. Thank you.
Great. Thank you. And thank you to everybody for joining us today. We really appreciate it. Stay well.